This is a case of unicornuate uterus where twice the patient failed with vaginal cerclage. You can see the right kidney placed in the pelvis, the right horn of the uterus is absent, the right ovary is directly connected to the inguinal canal. You can see how we are dissecting the uterovesical, opening the uterovesical fold, and we'll push the bladder down to expose the uterine vessels so that we will be able to take the cerclage tape medial to the vessels so that the vessels are not occluded and the blood supply is not compromised to the uterus. We are pushing the bladder down, and in laparoscopic cerclage the tape is exactly applied at the level of isthmus or internal os from where the weakness or the funneling starts. You can see how we are creating a cleavage between the uterine vessels and the isthmus. So once you are very confident that the uterine vessels are exposed and you have created a space, same thing is done posteriorly also. You open the posterior leaf of broad ligament and identify the vessels so that this is the Marcelin tape. So we are passing the needle from back side, from behind in front, and you can see how it is coming out on the medial side of the uterine vessels without injuring or damaging the vessels. You have to be careful not to injure the uterine vessels. These tapes, they have two needles, one on each side, so that makes your life comfortable. You can see how we are taking the other needle from on the other side, and finally you have to remove the needles and tie the knots. You can tie the knot in front and behind, but we prefer to keep it in the front side, and you can see you keep it tight. Normally we place a Hager's dilator number 6 in the cervical canal just to avoid complete occlusion. Normally we have never faced such situations, but you can see how we tied it. The extra length is removed. Then the next step is to close the uterovesical fold using a 2-0 vicryl or polyglactin suture. This is just to make the foreign body retroperitoneal. It should not be exposed in the abdominal cavity, peritoneal cavity. So normally these are less reactive than Prolene mesh. They cause less adhesion, and normally we prefer to take them out at the time of cesarean section. If there is no further pregnancy required, you can keep it there for a second pregnancy or subsequent pregnancies. That will be effective. So only challenge is if the patient has any mid-trimester miscarriage or mishap. In that case, how to take the baby out, that is a challenge. This is the final view how we have closed the uterovesical fold of peritoneum, and finally the needle is removed, and you have to ensure the proper